Dr. Surbi is going to present management of occlusio pupillae, secondary glaucoma, and complicated cataract, a case report.
Good afternoon, everyone. I'm Dr. Surbi Taneja. Thank you, AIOS, for selection of my poster for the Hyde Park. As we all know, uveitis, it affects 2 million people worldwide, and 10% of them, they suffer irreversible visual loss due to different complications like the retinal damage in glaucoma. Glaucoma is the third most common complication, the first two being the macular edema and cataract. And 40% of those patients can develop cataract. So in those cases where there is a cataract, uveitis, and glaucoma, it can be a very tricky case to manage. The cataract and glaucoma not only occurs due to the uncontrolled and sustained inflammation, but also due to the prolonged use of the steroids in all different forms. Chronic anterior uveitis can lead to occlusio pupillae, which can lead to a pupillae block glaucoma, and later on there could be formation of the iris bombay and a secondary angle closure can occur. So, a patient, 64-year-old male, presented with pain in the left eye, and he was a diabetic and had coronary artery disease and was on antidepressants. He also had a history of recurrent uveitis. All the tests were done for which there was no positive test. And the last attack was 8 years ago. The patient was already on anti-glaucoma medication, Dorzox, brimonidine, and timolol combination, and homitropin in the left eye. The right eye was, on examination, the right eye was within normal limits. And the left eye, the vision was perception of light was present, and the projection of rays was inaccurate. The IOP was 48 on GAT. Slit lamp showed circumcorneal congestion, corneal haze, and as you can see in this picture, the AC was very shallow. It was almost flat in the periphery, and there was occlusio pupillae present. Anterior segment OCT confirmed our findings, clinical findings. B scan was done to see if there was anything in the fundus because it was not visible. So what we did was, in such a case where there was occlusio pupillae present, we used ND-YAG laser to perforate that membrane to temporarily lower the IOP, which we did by setting it at anteriorly and at a very low energy. So the membrane, as it perforated, it led to the deepening of the chamber, as you can see in this E figure. And there was also a small hyphema, but that resolved, and we put the patient on the systemic and topical anti-glaucoma medications. OCT was done after that, but still, as you can see, the permanent synechiae had been formed, and the pressure, it lowered to 32 mm Hg. After 1 month of giving steroid treatment when the eye was quiescent, we took the patient for phacotrabeculectomy with the mitomycin C. And since, as I told you, it's a very tricky surgery, we needed to use do the synecholysis and use the iris hooks, and a trabeculectomy was done. Post-op on day 1, the bleb was diffused and the chamber was formed, and the pressures was normal. And at 1 month post-surgery, the IOP was 10 mm Hg, the bleb was well formed, it was diffused as wanted. The vision improved to finger counting 1 meter. And then the fundus was examined and it was total glaucomatous optic atrophy. 3 months post-surgery, the patient had the IOP on the higher side, and we added glucomol 0.5%. So for this case, I would like to say that these patients, management for cataract and refractory glaucoma is very demanding, and there's a high risk of the failure of the filtering surgery as well because they have more inflammation. So in such patients where the IOP is not getting controlled, we need to do a combined surgery. Literature says that we can do a phacotrabeculectomy, but if possible, then we should do a cataract first, and then we should go for the trabeculectomy. So that can be given as a choice to the patient also if the IOP is under control. However, if there is, and as you see that in this case, the patient had a vision of PLPR, and we just did not know how much recovery will be there. But in such cases also, a treatment trial should be given because we could actually give some vision to the patient, and finger counting 1 meter is very useful to the patients as seen in our OPD. Thank you so much.
Okay, I have a question. When you took the patient for surgery, the intraocular pressure recorded was?
Ma'am, the pressures were high post-op after 1 month, but the eye was quiescent.
Pre-op, before surgery?
Yes, ma'am. It was around 25 mm Hg, ma'am. And he was on Diamox, ma'am.
Okay, but then when you took the patient for surgery, the intraocular pressure recorded was 32 millimeter mercury?
No, ma'am. 32 millimeter was the pressure that we got when we did the ND-YAG laser for that membrane that we did, perforated the membrane. the chamber formed and the pressure lowered from 48 to 32. Not much, but it
and
could be
and
an intermediate benefit.
pre-op surgery, the day of surgery, 1 day prior, how much was
Yes,
the
ma'am. The
intraocular
patient
pressure?
had a IOP of 25 mmHg
Okay.
before the surgery as well. After 1 month of waiting for the eye to be quiet,
That's
because
what I was
we
thinking.
cannot go for the
Okay.
surgery.
And pre-operatively, did you give any anti-glaucoma medication or IV mannitol, anything of that
Yes,
sort?
ma'am. We gave a IV mannitol to the patient.
Did you? Was it mentioned here?
No,
I
ma'am,
think
it
I missed.
wasn't pre-op. It wasn't mentioned here. But whenever we take the patient for a phacotrabeculectomy or a trab, we give a IV mannitol to the patient.
And what kind of block did you use in such case?
We use a peribulbar block.
Okay, thank you.
Thank you, ma'am. Thank you, everyone.
Do you give? Do you use MMC in these cases or?
Yes, sir. We use most of the. So we use MMC except in the high myope cases. We do not use the MMC.
Even in the first surgery, you use MMC.
Yes, sir. We use MMC in the patient.
And do you do the trabeculectomy at the same site of the phaco incision or?
Two sides, sir.
Any particular reason for that?
So it has been quite successful, and in all our cases,
Nothing to do with uveitis.
so not particularly because of the uveitis, we do it two-side surgery only because the results are good in our practice.
When you are giving a paper like this, you should quote your references. You have not provided your references here.
Yes, ma'am.
Number one. Number two, you said something that like cataract surgery should be done before the trabeculectomy. I think with something like that, you should have quotations, I mean, from noted authors before, because it is questionable.
Okay, ma'am.
Number three is that the preferred choice right now for uveitic glaucoma, because of the high failure rate, is of course
A valve?
is a valve.
Yes, ma'am.
So
But depends on the affordability also, ma'am, of the patient. For
I
in
do
our
understand it. I do understand that you did do that, but I think it would have been
Yeah,
wise to
definitely,
mention
ma'am.
it.
Definitely,
All
ma'am. Thank you for comments. Thank you, everyone.